Intrapartum sonographic assessment of the fetal head flexion in protracted active phase of labor and association with labor outcome. A multicenter prospective study. Protracted active phase of labor is among the most common indications for cesarean delivery, and according to the international guidelines on ultrasound in labor, intrapartum ultrasound is recommended in conditions of first-stage dystocia. Looking at the mechanics of human labor, we know that the flexion of the fetal head is involved in the engagement and progression of the fetal head through the birth canal. However, to our knowledge, no research has evaluated the sonographic assessment of the degree of flexion of the fetal head in relation to the labor outcome in women with protracted active phase of labor. The aim of the study was to evaluate the relationship between the intrapartum ultrasound indicators of fetal head flexion and labor outcome within a selected cohort of women diagnosed with a protracted active phase of labor. This was a prospective study conducted across 3 tertiary maternity units in Italy and including laboring women diagnosed with protracted active phase of labor as defined according to the ACOG SMFM recommendations. At diagnosis of protracted active phase of labor, the included women were submitted to transabdominal ultrasound in order to evaluate the occiput position and the degree of flexion of the fetal head by measuring the occiput spine angle in fetuses in non-occiput posterior position and the chin-chest angle in fetuses in occiput posterior position. Obstetric interventions performed solely based on suspected intrapartum fetal distress represented exclusion criteria for this study. In this slide, we show ultrasound images of the sonographic indicators of flexion and station which were measured for the purposes of the study. Following the evaluation of the inclusion and the exclusion criteria, 129 cases were included, of whom 86 fetuses in non-occiput posterior position and 43 fetuses in occiput posterior position. Among the cases in non-occiput posterior position at diagnosis, those submitted to cesarean delivery showed a lower maternal age, a higher booking and term pregnancy BMI, as well as a narrower occiput spine angle and angle of progression, and a longer head perineum distance compared to the cases who had vaginal delivery. However, at logistic regression analysis, only the occiput spine angle and the head perineum distance proved to be independently associated with the mode of delivery. A visual analysis of the scattered dot charts showing the correlation between the occiput spine angle and head perineum distance and between the occiput spine angle and the angle of progression, cases submitted to cesarean delivery appeared to pool in 2 clusters. And while this first cluster seemed to follow the correlation between the flexion of the fetal head and the sonographic station, confirming that the mechanism of flexion represents a major determinant of the fetal head descent, 9 cases were identified as outliers as they showed a discrepancy between the degree of flexion and the expected station of the presenting part. The outlier cases showed a lower maternal height and a higher birth weight to maternal height ratio, which suggests that in such cases, the determinant of the cesarean delivery could have been represented by cephalopelvic disproportion rather than malpresentation. When evaluating cases with non-occiput posterior position and favorable head flexion as witnessed by an occiput spine angle above 109 degrees, outliers accounted for 9 out of 13 of all cases of cesarean delivery. The graphs shown in this slide demonstrate the distribution of the OSA to AOP ratio and the distribution of the OSA to HPD ratio in relation to the mode of delivery in outliers and in non-outlier cases. As it can be noted from the graphs, outlier cases were characterized by a higher OSA to AOP ratio and a lower OSA to HPD ratio compared to non-outliers. At ROC curve analysis, cutoff values of 1.2 for the OSA to AOP ratio and of 3.05 for the OSA to HPD ratio identified all outlier cases and were associated with an almost 70% sensitivity for cesarean delivery in this subgroup of cases with favorable head flexion. Among the cases in occiput posterior position at diagnosis, those submitted to cesarean delivery showed a wider chin-chest angle and a higher frequency of labor induction compared to the cases who had vaginal delivery. Both the chin-chest angle and labor induction proved to be independently associated with the mode of delivery at logistic regression analysis. In conclusion, the results from this study show that head deflection in the context of protracted active phase of labor is associated with an increased risk of cesarean delivery due to labor dystocia in occiput posterior and in non-occiput posterior fetuses. In non-occiput posterior fetuses, the degree of head flexion correlates with the transperineal sonographic indicators of fetal head station, and the head perineum distance is independently associated with the likelihood of vaginal delivery. In non-occiput posterior fetuses, the finding of outlier cases requiring cesarean delivery due to labor dystocia and characterized by no evidence of malposition and malpresentation in a high station suggests that intrapartum ultrasound may improve our understanding of the etiology of protracted active phase of labor. Thank you for your attention.